Tonight we're going to introduce you to a new website, BaptistHealthNeuroscienceCenter.com. And on that website is our interventional neuroradiologist, Dr. Curtis Given.
At Baptist Health, we truly provide a comprehensive care to patients and their families in regards to cerebral aneurysms. We have an extensive team of physicians that can provide all aspects of care. I'm Dr. Curtis Given. I'm a neurointerventional radiologist at Baptist Health.
My name's Gardner Trevelyan. I'm from Harrodsburg, Kentucky. And Dr. Given at Baptist Health is my doctor.
Gardner had come to see me because he had had a family member who had had a ruptured aneurysm.
My sister kind of went blind in her right eye, and they say it's hereditary, so all of my brothers and sisters had to be checked, and it was just her and myself that had an aneurysm.
Because of the size of his aneurysm and the location of the aneurysm, we felt like it presented a not insignificant risk. Our expectation is that most people will come in, spend a day in the hospital, 2 at the most, go home.
I had the surgery done on a Monday, stayed in the hospital, got out Tuesday, and I was back to my 12-hour shift on Friday. I still fish, hunt, ride motorcycles, work all the time. Nothing really changed.
At Baptist Health, we have state-of-the-art technology. We are very committed to the treatment of cerebral aneurysms.
Baptist Health was really good. All the nurses, the staff, it's kind of an atmosphere of just family.
And tonight, joining us on the set is Dr. Given, and they say you're a neurointerventional radiologist. Well, obviously you take care of some aneurysms, but you do a lot of other things too. Tell me exactly what all that means.
So a neurointerventional radiologist is I tell people it's very similar to an interventional cardiologist that does procedures like heart catheterizations through accessing the blood vessel in the groin, except that instead of working in the blood vessels in the heart, we're able to feed those same kind of catheters up into the head and work on the blood vessels in the head in a minimally invasive fashion.
Well, now, aneurysm can bleed, can cause stroke and death, but there's also, like Dr. Brooks talked about, some other types of strokes.
Yes, so the more common form of stroke, with a ruptured aneurysm being a hemorrhagic form of a stroke, would be the ischemic stroke, again, where there's a blockage of a blood vessel. And typically, that's from a blood clot that either has traveled from the heart up into the head or from a blockage in the neck and broken loose and gone up into the head. And when that occurs, time is very important, and as Dr. Brooks mentioned, you really want to try to get to the ER as quickly as possible to be a candidate for the clot-busting medicine within 4.5 hours or so. But even then, if it's a large blood vessel that's being blocked, that clot-busting medicine doesn't do a very effective job at dissolving that clot in a timely fashion. That's when we get called, and are the people that are having the big strokes, or in people that don't qualify for the clot-busting medicine because they're outside that 4.5 hour window, or they've had a surgery recently and they can't have the clot-busting medicine because of that. And in those instances, we're able to feed a tiny catheter up through the groin, again, like a heart catheterization procedure, and actually go up into the blood vessel in the head and physically pull out the blood clot to open up blood flow.
Is there a certain type of patient that you select for that, or is pretty much anybody who's had a stroke that's not responding a candidate?
Well, if they've qualified for TPA, typically then they're within a time window that we would offer them treatment. But then we do also non-invasive tests to help sort out which patients will benefit from that. Usually either a fancy CT scan or MRI that will hopefully tell us how big of a stroke is the patient having, and is that stroke already completed, or is it something that if we were able to open up the blood vessel, they might reverse some of the effects of the stroke and recover some function.
On the website, I also saw a video of an actual procedure that you did where the patient got basically all total recovery.
Yes, we're seeing that much more common. 3-5 years ago, we would have kind of the heroic save where somebody came in not being able to move one side of their body, not being able to talk. We would have that kind of a complete reversal maybe once a year, twice a year. With the newer devices that we have that are much more efficacious at opening up the blood flow and much faster, we're literally seeing those kind of heroic saves twice a month, 3 times a month.
And that can prevent just a horrible disability with a completed stroke.
Yeah, you're absolutely right. We're taking patients who, who were devastated, that were looking at having to live in some sort of assisted living facility or some sort of permanent healthcare facility to take care of them because they weren't going to be able to do that, to returning to work and being able to function almost back to complete normal.
All the more reason, if you have a symptom of stroke, get there fast.
Absolutely. Again, the biggest predictor is time, and the sooner we can open up those blood flows, open up those blood vessels and restore blood flow, the better outcomes we're likely to have.
Now, you mentioned TPA. That's one of the medicines used to dissolve the clot in blood thinner. Mm-hmm. Are there other medicines like that may prevent or treat stroke?
Right now, TPA is kind of the workhorse for acute strokes, people that are presenting within that 4.5 hours of symptom onset. But one of the problems is that TPA has very strict criteria as to who qualifies for that. So less than 10%, probably closer to 5% of people who have a stroke qualify for TPA. So while it's kind of the standard of care today, it is only given to the minority of patients. So that's where these interventional techniques that we have are able to give medicines and apply devices directly at the blood clot in the head with less of a systemic effect, less effect of the whole TPA on the body.
And when you go up you actually go up and get the clot. It's not
Yes.
like the heart where you put in a stent and open the artery. You go up and try to extract the clot.
Yeah, physically extract it. So there's this new class of devices called stent retrievers that look like stents that you put in the heart, and you deploy them in the clot. But what happens is they expand into the clot, and the clot gets integrated into the center of the stent. And instead of leaving that stent in, you then pull that stent out with the clot in it. And we're really achieving 9 out of 10 results at restoring completely normal blood flow.
Now, you mentioned stent. When you're dealing with the carotid artery, are there stents there that you sometimes need?
Yes, and Dr. Brooks touched on that, and that usually when we're applying stents in the carotid arteries, it's patients who have a severe blockage that are at risk for stroke or have had a stroke related to a blockage and we're trying to prevent another one. But it's people who, generally speaking, are high risk to have the surgery where they clean out the artery, or have had some sort of other contraindication to having the surgery. And so the typical things for that are if they had already had surgery once and the blockage came back, it's very hard to navigate through that scar tissue. And so generally speaking, that's a patient that we would employ a stent with. Or if they've had surgery to their neck before for maybe a cancer or had radiation, those are the classic instances when we would employ a stent rather than do surgery.
Are there times when you wouldn't go up to try to get a clot out of the brain and prevent a stroke?
Yes. So if you came in and we did the scans and it showed that you do have a blockage in the blood vessel and that's caused your symptoms of your stroke, but based on the scans, the special CTs, the special MRIs, that brain has already died, that it's already been too long, it won't help by opening up that blood vessel. In fact, that might cause bleeding into the area of the brain because that area of brain has already suffered an irreversible damage.
Well, that's great information, and that just reinforces that time is the essence to get the clot fixed before it damages the brain.
Absolutely.
All right. Thanks for your time. We appreciate you coming in. Great information. We'll be right back.